I am sorry that I could not be with you at the meeting. In addition, I would like to thank Ivan Goots and the organizing committee for the honor and privilege to present to this prestigious audience on gold standard and new superficial venous devices undergoing trials. Could they be a game changer?
These are my disclosures. What is important to you regarding ablation? Closure rate, patient acceptability, cost, affordability, cost effectiveness, profit, reintervention rate, complication rate. We know that one size does not fit all, nor is one thermal or non-thermal device perfect for all cases. What is the definition of gold standard? It denotes the best tool available at the time to compare different measures. There are always arguments against ourselves as to which is the best and what are we considering. Patient outcomes, risk benefit, cost effectiveness, insurance coverage. One of the first randomized controlled trials comparing different ablative devices concluded endothermal was superior to foam and surgery. Historically, we were asked to review the literature and write an article in 2014 whether non-tumescent ablation procedures were ready to take over. We concluded no. So let's look at the literature. In 2017, Enrico Asher and Anil Hingorani wrote Clinical Correlations of Success in Acute Thrombotic Complications of Lower Extremity Endovenous Thermal Ablation. And they found that there were no differences in efficacy between RFA and laser. In several other papers, there were the following conclusions. All endovenous treatments are safe. Low complication rates and morbidity. Interventions resulted in significant and clinically important improvement in symptoms and signs. All interventions resulted in significant improvement in quality of life. In 2017, Lawson also looked at the comparison between RFA and now the 1470 laser and concluded in 346 limbs that RFA and 1470 laser were equal in efficacy and postoperative recovery. Dr. Ballant reported in 2017 in JVS VNL that RFA and endovenous laser are equal in long-term success. Looking at laser, RFA, and foam sclerotherapy, Professor Bittenden reported in the New England Journal of Medicine in 2019, looking at 5-year outcomes, that disease-specific quality of life 5 years after treatment was better after laser ablation or surgery than after foam sclerotherapy. The majority of the probabilistic cost-effectiveness model iterations favored laser ablation at a willingness to pay ratio of approximately 20,000 pounds or $28,000 per quality. Now let's look at non-thermal, non-tumescent treatments. Listed before you are the following non-thermal, non-tumescent treatments. Does size matter? It appears to, as the non-thermal limitation by the FDA trials were less than 12 millimeters. Looking at quality of life and occlusion rates at 1 year, quality of life improvements are all about the same, whereas physician-compounded foam falls below the occlusion rate of 90%. As we look at the comparison of pitfalls, major differences are apparent. However, nerve damage, thermal, phlebitis, non-thermal, granuloma, cyanacrylate, recurrence, physician-compounded foam. In the Journal of Angiology, Professor Alan Davies concluded that thermal treatment with RFA or endovenous laser ablation is the mainstay of varicose vein treatment, Both RFA and laser appear to have similar efficacies. The new European Society for Vascular Surgery 2022 guidelines support thermal ablation for great saphenous vein. Treatment is the gold standard. As you can see, the first tier is thermal ablation. The second tier is surgery and glue. And the third tier is mechanical, chemical, catheter-directed foam, and ultrasound-guided foam sclerotherapy. Finally, for SSV treatment, thermal ablation is the first choice treatment modality. At Charing Cross in April of 2024, Professor Manj Goel and Dr. Kathleen Gibson announced the results of the VenaSeal Spectrum study. VenaSeal performed similarly to both surgical stripping and endothermal ablation in terms of elimination of truncal reflux. 6-month effectiveness data showed that VenaSeal was not inferior to surgical stripping with similar anatomical closure rates. The equivalent measure was not tested between VenaSeal and endothermal ablation. At 30 days, participation in both the glue closure and stripping arms were similarly satisfied post-procedurally. If we look at an independent market analysis, the blue arrow and the red star, you can see the following. Regardless of the percentages of thermal ablation versus non-thermal ablation, thermal ablation will continue to be the go-to devices for truncal ablation. There is an estimated 1 million treatments, 425,000 RF treatments, 200,000 laser treatments, 138 glue treatments, 240,000 Varithena treatments. So let me be the fortune teller. Is thermal ablation the gold standard? Let me look into my crystal ball. My crystal ball says yes, 2019 to 2027. Now let's look at the Ouija board. Is thermal ablation the gold standard? Yes. Ladies and gentlemen, in conclusion, there appears to be clinical equipoise amongst the ablation procedures. No perfect device at present for all superficial venous disease. Cost of materials versus reimbursement, insurance approval, financial incentive, and physician preference is multifocal. As of now and 2027, there's not one perfect modality. Each has their sweet spot. Thermal has a long track record and for larger veins. Non-thermal is shorter procedure and nerve sparing. My recommendation, if you can only afford one device, thermal ablation, the gold standard. Thank you for the opportunity to present to you.
Now let's look at some new devices undergoing trials. The Envira device is aiming to become the world's first mechanical only ablation device for superficial venous reflux disease, offering a non-thermal, non-chemical, non-implant approach to treating chronic venous disease. It is composed of a nitinol helical ablation coil for mechanical disruption of the vein wall inner lumen. This is delivered with a flexible catheter compatible with a 5 French introducer sheath. The thumb wheel-based handle enables precise deployment of the echogenic coil in the venous anatomy under ultrasound guidance. The procedure utilizes standard minimally invasive techniques and is easy to visualize under ultrasound as shown in the video on the right. The withdrawal rate of 2 to 4 seconds per centimeter. An initial safety study of the helical coil platform was performed in 2021 in Europe. From the first patient cohorts treated, there were no DVT adverse events noted after the initial 11 patients treated. Patients reported minimal or no pain during treatment and improved clinical and quality of life improvements at 12 weeks. A Gen 2 ablation coil has been developed to see if there will be significant gains in efficacy. Let's look at another device called the Amcell Secure Clamp, which is a self-sealing nitinol clamp delivered through an 18-gauge needle. Depicted in this slide are the range of applications: venous disease, trauma, robotics, and laparoscopic. Let's look at the animation video. As you can see, this is a relatively simple process. The first in-human safety study with a secure clamp, the average procedure time was less than 10 minutes. High safety profile with follow-up on 12 months. Improved quality of life outcomes. There was a need for a change of the delivery device to make it single-handed. The company plans on a limited FDA study for the percutaneous device in Q4 with FDA approval and commercialization in 2025. The Soludio device, as depicted here, could be a game changer for thermal ablation. As you can see, there is internal and external tumescent anesthesia delivered. If we look at the comparisons between the different anesthesias, there are potential gains with Soludio. Most of us perform these procedures under tumescent anesthesia in our office. The Soludio method of delivering tumescent anesthesia causes less pain. With general anesthesia or LMAC anesthesia is more complex and immediate recovery from such is longer. As you can see, the first-in-man clinical study, there were 9 consecutive patients. The importance of this is looking at pain scores during deployment of tumescent anesthesia. If we look at this timeline, it is believed that the U.S. commercialization will happen in 2025 as well as Europe. Let's look at HIFU. The operator positions the treatment head of the patient's leg. The fine-tuning of the positioning is controlled by the system. Echo therapy can be safely applied 2 millimeters from the saprophymal junction, literally eliminating the risk of stump formation after treatment. The beam can follow virtually any path, even tortuous veins, regardless whether big or small. The unit has 2 functions. The 3 MHz transducer creates the high-intensity ultrasound waves focused in an area as small as a rice grain, depositing heat up to 85 degrees Celsius, and that totally extracorporeal. Embedded is a 7.5 MHz transducer for real-time ultrasound imaging. To avoid skin reactions, the coupling part of the head is permanently cooled by a circulating liquid system. Let's look at some of the results. Methodology: Group 1, HIFU only. Group 2, HIFU followed by foam sclerotherapy at the same session. Group 3, HIFU followed by delayed foam sclerotherapy. HIFU only. At 8 weeks, there was an 80% successful closure. At 1 year, there was a 40% successful closure. HIFU plus foam sclerotherapy. At 6 months, there's a 100% successful closure. At 1 year, there was an 88% successful closure. HIFU plus delayed foam sclerotherapy. Truncal veins last scan before foam. 82% successful closure. At 1 year, 91% successful closure. The investigators concluded that at 1 year, results suggest that HIFU is an effective treatment for venous reflux in truncal veins. Foam sclerotherapy may improve results in truncal veins. Further work is needed to study most effective protocols for HIFU and foam sclerotherapy. In the U.S. pretrial, 20 great saphenous veins were treated. Primary endpoints were safety and efficacy. Secondary endpoint, no reflux or closure. 3 to 5 day and 3-month follow-up. There were 18 patients, 20 great saphenous veins, 80% were C2. The diameter pre-treatment average was 7 millimeters. Results of 3 months, 100% technical success, no anesthesia, no post-procedure compression. Ablation of venous reflux, 95%. Ablation to flow, 65%. 7 with great saphenous venous with flow, patent but no reflux, 6 out of 20. Patent with reflux, 1 out of 20. Patients rated pain of the HIFU treatment, 20 out of 100. No complications, no nervous skin injury, DVT or SVT. VCSS score dropped significantly at 3 months. For HIFU, we need to identify the right patient, vein size maybe less than 10 millimeters, vein depth with compression 10 to 20 millimeters. There is some discomfort during treatment. Treatment time 60 to 75 minutes for 10 to 15 centimeters. There's need for further modification, speed, and cost. Thank you very much for your attention.